Hello, YouTube and Rumble. Welcome back to another YouTube video. Today I'm going to be talking about paramedic patient assessment and everything that has to do with assessing a patient on a paramedic ALS advanced life support level. For a lot of you that don't know me, my name is Chase Parker. I'm 19 years old. I've been an emergency medical technician for 2 years because I did my class and became an EMT when I was 17. And that's what I've been doing work wise for the past 2 years. And I'm now in a paramedic course, and I'm going to start making content in regards to teaching it to help myself learn, as well as possibly educate others. So I've pretty much made an entire PowerPoint that essentially explains. Let's say you're a paramedic on a 911 call. You get a call, say for XYZ problem. What is going through your mind? What are all the questions that you need to ask yourself as you arrive on scene and you start assessing a patient from the very get go, no matter what the problem is, right? So, our appearance. The first thing when let's say we get a call, say we get dispatched to, say, someone's house, and we walk into the door after we make sure the scene is safe, of course, and we see the patient. Before we even start talking to the patient, before we arrive on scene, we can start already assessing their appearance. So the very first things that we're going to notice when we look at the patient is, okay, our what we call a general impression is the very first thing we do. Their facial expressions. How are they looking? Are they in any pain? Do they look like they're irritated? What's their skin color? Are they pale? Do they have normal skin color? Is their skin red? Because I mean, are they cyanotic? Are they low on oxygen? That can tell us a lot of things as well. Are they making eye contact with us? Are they unconscious? Because if they're unconscious, they won't be able to make eye contact with us. How much do they weigh? If they're obese, do we maybe need to call help to help someone move the patient on a stretcher, possibly? Are their breathing effort? How are they breathing? Are they breathing normally? Are they hyperventilating? Are they not breathing? What's their posture? How are they sitting? Obviously, in regards to just going into any home or any location, um, what's the odor? Like, how does the patient smell? How's the patient hygiene? If the patient looks like they haven't had a shower in 2 weeks, or they have really long nails or really long hair, that might be something we want to inquire about. So, just as soon as you find a patient, these are already things that are going through your mind that you need to be considering before you even talk to the patient, right? And our levels of consciousness. So another thing that we can assess when we first get on scene with the patient is their levels of consciousness. So um, are they talking to me? Right? What kind of mood are they in? Our AVPU is we call it AVPU in EMS is a way for assessing patient basically responsiveness. So AVPU, it basically rates their level of alertness. So are they just alert? So when I say, hello, how are you? Do they just start talking to me? Then they will be alert. Are they alert to verbal stimuli? So do they only respond to me, say, when I yell at them? Then that would be alert to verbal. Are they only alert to pain? So say they don't respond when I talk to them, but they do respond to say when I pinch them, they say ow, or are they unresponsive? So keep in mind, and then A and O, we rate it on a scale from A and O times 4. So you want to see if a patient is alert to place, time, event, and place, time, event, and person. So you can ask them their name. You can ask them if they know where they are. You can ask them, um, like, do they know what day of the week it is? Or ask them a simple question that anyone should be able to answer, like how many quarters in a dollar. And you can also assess their memory. So as soon as we get on scene with a patient, we want to already start identifying, like, hey, what are we dealing with? What is the patient responsive to? Are they unconscious? Do we need to call anyone else? Um, what's happening, right? And then obviously, we get a baseline set of vital signs when we're on the scene, right? So, assuming that the patient doesn't need any immediate life-threatening resources, which on most calls they're not going to, we always get a baseline set of vital signs. So, we're going to take the patient's pulse. You could take the pulse. I mean, most times you have a little SpO2 reading that you put on the finger that'll check the pulse. But if someone is unconscious, you check their carotid pulse first to see if you need to do CPR, or you could check at the radial or the brachial pulse, right? And then obviously you can measure their respiratory rate and their tidal volume. So respiratory rate is just how many breaths they're breathing per minute. So that can be measured by just counting their chest rise and fall, so just seeing how many breaths they're doing per minute. And tidal volume, so are they getting adequate oxygen? So I mean, that'll tell you a lot about how they're breathing. So if someone is hyperventilating, then they might not be getting enough oxygen, correct? Or they're having trouble breathing. And if someone isn't breathing, they're definitely not having enough tidal volume, because tidal volume, I believe, is just the amount of oxygen that you're getting inside of you. You can take the patient's temperature to see maybe if they have a fever. It could be a sign that they're septic or they have an infection. SpO2, which is how much oxygen they have. So 93 to 100% is normal. Obviously, you're looking at skin temperature, because anything, a skin. Another thing that I've learned is someone's skin condition is basically another vital sign. Just like having a pulse or having a temperature, like skin condition can be a vital sign, because depending upon someone's skin color or their temperature could tell you a lot about them, right? So when you're assessing skin, look at like obviously color, like moisture, like you can pull it. It's called skin turgor. You can pull at the skin to measure the skin turgor to see how moist it is or how dry it is. And obviously, like you can check for lesions or any cuts or any external bleeding. Because, for example, let's say you get called to a patient and they have, say, a jacket on like this, and you say fail to assess the skin, you might not notice that they have a huge rash on their right arm and they're in anaphylaxis. So you got to always assess the skin. Also, assess the pupils with the pin light with the acronym PERLA. So PERLA stands for pupils equal, round, and reactive to light, I believe. Because when you're assessing the pupils, you want to make sure that the pupils are equal in size, they're round, and they're reactive to light. So most EMTs, we have what's called a pin light, which is it's literally a pin that you have a flashlight and you can just shine it in the eyes for a second. And typically, when you shine that light in the eye, you want to see the pupil start to temporarily constrict as soon as you shine that pin light in the eye. And then when you move the pin light out, you're going to see the pupils dilate. So what you're looking for is that reactivity to light. So if, say, someone's pupils are unequal, so say like one pupil is constricted and one is dilated, then that could be a sign of a stroke or traumatic brain injury. Could also be a sign. Anything that has to do with dilated and constricted pupils could be a sign of like a drug overdose, depending upon if they're constricted or dilated. It could be an opioid or a narcotic. End-tidal CO2, which is just a way to, is another vital sign that can be measured by putting capnography on, is a way to basically just measure the amount of carbon dioxide a patient is exhaling, which is another thing that's good to know. And then obviously you want to ask the patient if they're in any pain, and you could say, measure this by rate how much pain you're in and scale from 1 to 10, and they'll tell you how much pain they're in. And so obviously some patients will exaggerate it. You'll ask them, hey, how much pain are you in? I'll scale from 1 to 10, and they'll say 10 out of 10 just because they want pain medicine. But in reality, if a patient says they're in a lot of pain and yet you put them on the monitor and their blood pressure is normal and their pulse is normal and they're breathing normally and they're not screaming and being agitated, you know that they're lying to you. So this is a good thing to know. Secondary physical assessment. So um, obviously, when we arrive on scene and we get called to a patient, there are other things that we notice on first. So we notice how the patient is talking to us first. We can get a good baseline of the general condition by just talking to the patient, allowing them to tell us what's wrong, allowing them to tell us what we can help them with. See, keep in mind, our job in EMS isn't necessarily to fix whatever their underlying problem is. Our job is just to reassure them and be nice to them and get them to the hospital if they want to go, while meanwhile doing whatever we can to help stabilize them or keeping them alive for the time being. That's basically what the job is. So, getting more in depth here, if we had a more critical call, the very first thing that we want to assess on a patient is our XABCD. I mean, that's how I like to call it, XABCD. So when you first arrive on scene, as I mentioned, we could assess our patient's like level of consciousness, their cognitive ability. That can also give us a good insight into what their problem is. We can talk to the patient, but if we have a more critical call, where say we get on scene and the patient isn't responding to us, or say we get on scene and the patient is visibly bleeding or has a visible like puncture or say like a wound, then this is when we can get into more of a critical assessment. So usually when you get on scene with the patient, the very first thing you're going to go through is your XABCD. So X stands for external bleeding, A stands for airway, B stands for breathing, C stands for circulation, and D stands for deformities or cognitive deformities. So when you get on scene first with a patient, your very first thing is, okay, are they bleeding? Because if they're bleeding, then we need to take care of external bleeding first. Because if someone is bleeding but they don't have a pulse, yes, they're in cardiac arrest. But if we don't take care of that external bleeding first, while we do start CPR, they're just going to bleed out and they're going to die anyway. So our very first thing that we need to assess is external bleeding. And then if they're not bleeding, which most patients are not going to have external bleeding, I hope so. I mean, I hope you don't work in a 911 agency where half the calls you get the patients are bleeding. That would be terrible. But once we can assume that the patient isn't bleeding, we want to make sure the patient has an open and patent airway and that they're breathing. Because I mean, if someone isn't breathing, then I mean, like it doesn't matter what their problem is. We need to get them breathing, right? So, um, do do they have an open airway? So the best way to assume if a patient has an open airway is, are they talking to you? If a patient can talk to you like I'm talking to you now, they have an open airway. If their airway isn't open, then okay, we need to get that fixed first, whether it's doing a Heimlich maneuver, removing something that might be stuck in the airway. Maybe we need to intubate them. Maybe we need to BVM them to get them breathing, right? So, airway, breathing, make sure they're breathing, and circulation. So, once we've assumed and made sure that they don't have any life threatening bleeding, that they're breathing, right, and they have an open airway, we can check the pulse. So, do they have a clear carotid pulse? So, most of you can feel your carotid pulse right here at the neck, and you can also feel your radial pulse here at the neck. So, if we get on scene and someone's unconscious, the first thing we're going to do is check the carotid pulse here at the neck. And if they don't have a carotid pulse, then they don't have a pulse, then we have to start CPR, right? And then D is deformities, so or mental deformities. So as I mentioned earlier, what's their level of consciousness? Are they A-No times 4? Can they talk to me? Are they alert? Because if they're not, then that's a sign that there might be something else underneath that we might need to fix as well. And let's say we get a trauma call. Most calls you get aren't going to be trauma calls. Most calls are going to be medical. But say you go to a call, say motorcycle crash, and you have a patient that's laying supine on their back on the road. We would immediately want to do a rapid trauma assessment, also known as DCAP BTLS. So when we go through a rapid trauma assessment, we're looking at the patient. So keep this in mind: DCAP BTLS. So deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, um, lacerations, and swelling. These are all basic things that we want to immediately look at the patient. So, say if there's a motorcycle crash, we're on scene, we're immediately looking at, okay, like, is there anything deformed? Are there any punctures? Are there any burns? Is there anything swelling? Is there any tenderness anywhere? Right? These are all basic things that we're getting within the first 5 minutes of being on scene, right? And then ocular movements. Can they move their eyes? Can they move their eyes? Right? Like, can they look at me? Um, and then other things that you would look at for a trauma session is look at the ears. Can they hear? Is there any damage to the ears? Is there anything coming out of the ears? You could do the halo test, which is where you basically take a cotton ball and you put the cotton ball up to the ear when their ear is bleeding. And if you see like white fluid with a ring of like blood on the outside, that is a sign that they have leaking cerebral spinal fluid coming out of their ear. And spiral fluid is basically the fluid outside of the brain. So if you see that, that is a good thing to note to the physician when you get to the hospital. Um, and then looking at the nose, like if someone's had a trauma, is their nose deformed? Can they breathe out of their nose? Can they open their mouth? When they do open their mouth, how's the color of their mouth? Is their mouth pink and moist, like it's supposed to be, or is it pale? If it's pale, they might need oxygen. They might be cyanotic. And their jaw tension, can they move their jaw? On some calls, for example, someone's jaw might be really, really tense, and you might not be able to open it. So that's a good thing to note. And if you can't open it, you can't intubate someone if you need to. I once had a call where there was a lady and she was in cardiac arrest, and the paramedic I was working with was attempting to intubate her, but her jaw was just so tight that there was no way to even intubate her. It wasn't possible. Nothing to know is JVD, so jugular vein distension. I can Google it right here. JVD is when someone just has very, very just like bulging like veins in their neck. So basically, this is a sign of CHF or congestive heart failure. Congestive heart failure, because with CHF and JVD, congestive heart failure is basically when there's fluid in your heart and it's not basically fluctuating normally. So your heart basically, keep in mind, is pumping blood to the rest of your body, right? But if there's a lot of fluid buildup, a sign of that is you're going to see a lot of fluid build up in the neck. So you're going to see veins in the neck just start bulging. And that's called JVD. So if a patient does have JVD, that might be a sign that you might need to give them CPAP. Another treatment for COPD is nitroglycerin if it's indicated. Um, yeah, because basically they have fluid buildup, and that's a sign that a patient might have heart failure, which is just something to keep in mind. And then obviously is the trachea midline. So say when you look at someone's trachea, like you look at me, my trachea is midline, it's in the middle, like it's normal. But say if you have a patient where their trachea isn't midline, like say it might be going off to the side, um, that might be a sign that hey, like maybe a patient they have a collapsed lung and their lung is pushing their trachea to one side, and that might uh, be the sign of a pneumothorax, and you might need to do needle decompression, right? So keep in mind, in the field of EMS, especially just as an emergency medical technician, even as a paramedic, a lot of these things you're keeping note of. But it's always really good to make sure you do a good, thorough assessment of your patient, because unlike any other medical profession in the field of EMS, you have literally no idea what you are walking into. And that's the thing that's so interesting about medicine is everyone's body is completely different. So say we could have two different people and they could all have the same complaint. So say we could have one guy, he complains of chest pain, and another guy complains of chest pain. But unless we do a thorough assessment, we wouldn't be able to find out that two people are having two completely different problems. So that's the thing that's so interesting about medicine is you could have two people with the exact same complaint, with the exact same signs and symptoms, but unless you do a further assessment and you do a good patient assessment, you might not find out that they could have two very different problems. Another example of this is with chest pain. As I just mentioned, chest pain is a indicator also of having a heart attack or myocardial infarction, right? So if someone has chest pain, very first thing that we're thinking in our head is a cardiac issue, correct? So, but the thing that's so interesting about chest pain is, for one thing that I've learned with just doing this is most men when they feel chest pain, um, they could be having a heart attack, right? But women, just in general, they could be having a heart attack, but they could feel, say, pain in, say, their arm. So you could get a call for, say, like, especially you get an older lady, she'll say, I have pain in my arm, right? And you might not suspect that it has anything to do with a cardiac issue. But unless you do a cardiac assessment and you put on an EKG, you might have completely missed that it was a heart attack. And I've had that happen one time where you get called, say, an older lady. She says she has pain in her arm. And it turns out when you put the EKG on her and you do your cardiac assessment, you'll find that she was having a massive heart attack. And you wouldn't have been able to find that out unless you did the full entire patient assessment. So that's why it's important that you have to assess everything. Yes, it's tedious. Yes, it can get extremely annoying, especially at 2 in the morning when you're sleep deprived and you're on a call and you have to go to school the next morning. You still have to make sure that you're doing your entire patient assessment, because if you don't, you can miss very, very important things. And as I mentioned earlier, you could have two guys that complain of chest pain. One guy might be having chest pain because he's having a heart attack. The other guy might be having chest pain because he's in anaphylactic shock and his lungs are tight. And that's why he's having chest pain, because he can't breathe. In one case, this guy needs an albuterol treatment, and this guy, he needs nitroglycerin and aspirin. So two completely different treatments for basically the same person that's having the exact same complaint. But you wouldn't have been able to find that out if you didn't do your patient assessment, right? Another thing to assess with trauma patients is like their arms and their hands. So when you're looking at someone's arms and their hands, like, can they move their wrist? Can they move their shoulder? Right? Are there any deformities to the extremities? Are there any wounds? Another thing to check is pulses, right? So as we mentioned, this is your radial pulse here, and this is your brachial pulse. So say if someone doesn't have a radial pulse, that could be a sign that they're not getting enough blood circulation to their arm. So always check your pulses in your extremities. As for assessing your chest, when most patients, like, say if you're having a cardiac arrest, you're gonna like cut off their shirt, obviously, so you can assess the chest. So you're looking at their chest. Um, are there any wounds? Is their rib stable? Like, you can palpate it, so you can feel it. Like, are there any deformities? How does it feel when you touch it? And then obviously listening to your heart sounds. So say if I have a stethoscope and I listen to the heart on a normal beat, you should hear, like, it's called S1 and S2. When you hear a heart, it should you hear that double beat, like that bump bump, and it should sound like a lub dub sound, like bump bump. Should sound like a lub dub. But like I said, as I mentioned, if you have some patients where, say, they have like heart failure or they have fluid backup, like if you listen to their heart, you might not hear that normal lub dub sound. You might hear like a, how can I say this? You can just tell that you can hear the fluid, right? And also, say if someone is having like um they're really tachycardic and they have a really fast pulse, you can hear that. Like, you can hear the heart beating really, really fast. And also listening to lung sounds. Listening to your lung sounds are very important. You can just take the stethoscope, listen here, here. I have a chart here of where you can listen to your lung sounds. So say you can listen to lung sounds of the trachea, which is right here. Your brachial lung sounds, which are in here. Bronchovesticular, which is down here. And then your vesticular, which is pretty much all of your lungs. A lot of these are really specific just for class purposes. But in the field, when you're actually doing this, just listen all over. Just listen all over and get what you can. If someone has normal lung sounds when they breathe and they take a deep breath, you're going to be able to hear the exchange of air. You're just going to be able to hear the exchange of air. But say if someone is wheezing, you're going to be able to hear that wheezing. If someone has rales or fluid in their lungs, you're going to be able to hear that wet lung sound. You're going to be able to hear that they have water in their lungs. And if say someone is sick or they have bronchi or pneumonia, you're going to be able to hear that like gurgly, um, just nasty kind of fluid build up when they breathe. So, what might be good for some of you, I know is something that would be good for me, is like practice listening to some lung sounds because you need to get very good at hearing lung sounds and understanding what's actually going on with the patient. Because that's the entire thing about EMS. It's a lot of these calls that you go on, like, yeah, when you get a call, say at 9 or 10 in the morning when you're completely awake and you haven't been clocked in for 20 hours, you're going to be able to get all this stuff. But I mean, a lot of the calls, especially when you start doing 24-hour shifts, like I've done, you're going to be doing these calls like 1 or 2 or 3 in the morning, and it's going to be pitch black and it's freezing outside, and you're going to be extremely exhausted and you're already thinking about things you have to do for the next day. A lot of this stuff you're just going to have to know by muscle memory because a lot of these calls, like you're going to be extremely sleep deprived for some of them. You might have been busy all day. So you need to really know this stuff basically with muscle memory because, like I said, when you get that call at 2 or 3 in the morning and you're absolutely exhausted, the only way you're going to be able to do it is just by knowing it by muscle memory. So it's very important that you do a good patient assessment. Because here's another example, right? Um, if you watch my EMT basic drug video, I basically explained all these drugs that you need to understand how to use to be an emergency medical technician. That was back in October. It was like 5 months ago. I just made it for fun, right? So say you get on scene, you have someone complaining about they're having difficulty breathing. So if someone is wheezing, you would give them albuterol because albuterol is a drug that is a bronchodilator because dilate means open up, correct? Dilate is a drug that opens up something. If something is a bronchodilator, it opens up the bronchioles, right? So I can just Google bronchial. Your bronchiole is your lung, right? So if someone is having trouble breathing, you would give them albuterol, which is a bronchodilator, which means it opens up the bronchiole. Which, if someone is wheezing, they have tight lungs. So when you open up that those bronchioles, it's going to make it easier for them to breathe. And that would be what you would do if you have a patient who obviously is wheezing because they have tight lungs. However, you could get a patient where they also call and they say they have a breathing problem and they feel like they can't breathe. Okay, what if they can't breathe because they're having congestive heart failure or they're having pulmonary edema, which is water in the lungs? So the problem is, if you don't listen to their lung sounds and you don't find out they have wet lung, you can miss that they have water in their lungs. So let's say I get on scene and I get a call for someone says that they have a difficulty breathing, right? So in my head, I'm thinking difficulty breathing, give them albuterol, right? The problem is if you give albuterol to someone that has fluid in their lungs because you forgot to assessment, now you've given them a drug that opens up their bronchioles. Keep in mind, they already have water inside of their lungs. So if you give uh, albuterol to someone who already has water in their lungs, you're going to do what's called flash them, which basically you're going to drown them in their own fluid. So if you give albuterol or nebulizer treatment to someone who has water in their lungs, basically you're going to be opening up their airways even more, and you're basically just going to drown them in their own fluid. It's called flashing someone. And keep in mind, I've learned all of this the hard way. I've learned all of this by failing TSOPs and by making wrong judgments in the field where I've had to been corrected. So it's very important that you do a good patient assessment. So flashing EMS, it's going to bring up pictures of light sirens, whatever. But it's called flashing someone, where you basically have someone who they have a lot of fluid in their lung, and then you give them a drug that opens up their lung, and you basically just drown them even more in their own fluid. And you could kill someone. So that's why, as I mentioned earlier, it's very important that you do a full patient assessment and you basically listen to your lung sounds and you know what your lung sounds sound like, right? And then with just assessing the back, I mean, when you're looking at the back, make sure everything's equal in shape. There's no scars. There's no open or closed wounds. You can palpate the back looking for tenderness and rigidity. So rigidity, if I believe, is just dry blood, basically in the inside of the body. So if I want to look this up, in 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 not mental rigidity, rigidity EMS definition. Rigidity refers to the stiffness or rigidity of the muscles or joints. It can be assessed during a physical examination or the abdomen. Rigidity may indicate underlying trauma or internal organ damage. Yeah, so when you're assessing like basically the abdomen or the chest and the back, you can palpate it. And you can palpate it by say like just push on it. And that will, depending upon if the patient says they're in pain, that could be an indication that maybe there's an organ issue, right? Or there's internal bleeding. And then if you suspect that, then you have another subset of questions that you need to go into. So you can ask them like, hey, like, when did you last eat today? What's your surgical history? Like, do they have their appendix or their gallbladder or all their organs that they're supposed to? And then you can even inquire about, hey, have you been going to the bathroom recently? What color has your stool been or your poop been, basically? Because if they tell me that um, their poop's been red, I mean, they probably got some internal bleeding going on. Or if they're vomiting and their vomiting is black, keep on. I'm pretty sure I have a good idea of this. But say if they're vomiting, say like black stuff, then that's a good indicator that they're vomiting up dry blood. And if they're vomiting up dry blood, then that's probably an indicator that they have um, like something going wrong in their abdomen. They're bleeding in their organ system down here in their stomach, right? But if they're just throwing up red blood, then that's fresh blood. So all of this is stuff that you can look into and you want to assess, right? And then with the abdomen, um, same thing, looking for any like scars or wounds or distension. The thing is with distension and auscultation, so you can also listen to abdomen sounds. You can listen to stomach sounds just like you would listen to the heart. Another thing is with distension is if you get on scene and you look at someone's abdomen and their stomach is just really, really puffed up, that's a sign that they're bloated. So, I mean, if they're bloated, then that could be a sign that maybe they have a lot of air in their airway, they have a lot of air in their stomach, they're really bloated. Maybe they just need to go to the bathroom. Um, Another thing is, a lot of you may not understand what intubation is, but when you're intubating someone, you're basically putting a pipe inside of their trachea. But if you intubate someone incorrectly, and you don't put it in the trachea, you put it in the esophagus, and then you're blowing air into the esophagus, you're going to see a lot of distension and you're going to see a lot of air come up inside of their stomach. So look for distension, making sure you're feeling for the abdomen. So they call it the 4 abdomen quadrants. So say if someone says they're in pain in their abdomen, you would want to basically push on the abdomen and basically find out where they're in pain at, right? Especially for a lot of say you get called to a 22-year-old female, right? And they ask about abdomen pain. That's something that we would really want to look into because obviously there's a pregnancy chance with that, right? So that's just abdomen assessment. And then with male and female genitalia, yes, you have to inquire about this as well if it's indicated. Like keep in mind, with a lot of these calls, once you do it long enough, you can tell if a call is BS or not. But I mean, if you have a really critical call, then yeah, you probably want to make sure you're assessing everything. So say like what I mentioned earlier with the trauma patient, say pelvis stability. So if someone's just been in a car crash, like feel their pelvis, feel their hips. Is their pelvis stable, right? And then male genitalia, wounds, rashes, lesions, drainage, and priapism. Or am I even saying that right? I'm not gonna Google that, but proprioplasm. I don't even think I know how to say it correctly. Sorry. Um, it's basically just a prolonged erection. So when you're doing your assessment, you're basically just feeling everything. So I mean, you'll notice it, and once again, that's something to note to the physician or the nurse when you get to the hospital. And then for female genitalia, same thing: wounds, rashes, lesions, drainage, and if they're of like childbearing age, you want to ask about bleeding too, right? Because, for example, I did a call literally last week where it was a 23-year-old female, and she had been bleeding for like 4 weeks straight in that area, and um, depending upon if something's going down there, you could bleed out. So I mean, if you keep bleeding and keep bleeding and keep bleeding, then that could be dangerous to your own body, right? The problem with her is she was like 23 and she had had like 5 kids. So she was a 23-year-old and she'd been basically having kids ever since she was 18. So the problem with that is when you're 23 and you've already had 5 kids, you're not really giving your body the time to recover like your body needs to. So that just might be a sign of why you would have a bleeding problem like that. But I mean, just with any bleeding problem, as I mentioned earlier, if someone's having a lot of hemorrhage, they could bleed out, right? And they could go into hypovolemic shock. So something to inquire about. And then with your legs and your feet, same thing with your legs. You're looking at like symmetry, deformity, range of motion. Can they move their legs? What's their leg color? Um, any wounds, and then also feeling the pulses as well. So you have your femoral, your popliteal pulse, and dorsalis pedis. So my head is kind of in the way here, but I can move this image here to the side. This right here is basically a point of all the major pulses in the body. So you have your carotid pulse, which is the one in your neck, right? So a general rule of thumb is if someone has a drop in blood pressure, the the carotid pulse is going to be the last to go, right? Because it's closest to your heart. So say if someone has a drop in blood pressure, then obviously their pulses in their hands and their legs are going to go out first. That's why if there's an unconscious patient and we suspect that they're in cardiac arrest, we always go straight to the carotid pulse. Because if they don't have a carotid pulse, then they don't have any pulse, right? So if someone has a really low blood pressure or a lower blood pressure than usual, then they might not have a strong radial pulse or a strong pedal pulse at the feet. But though they still will have a carotid pulse. So a normal blood pressure is 120 over 80. So say if we have someone that has a really low blood pressure, like I mean the lowest blood pressure that I've seen on like a medical transport. Excuse me, I've only been doing this for like 2 years. I haven't been doing it for like I haven't had like a 20-year career, 30-year career in EMS or like a medical career. Like I probably will, but but yeah. So if someone doesn't have a carotid pulse, they don't have a pulse at all. But yeah, these are some good pulses. You obviously need to know all of them. So your carotid is at your neck, your brachial is at your elbow, your radial is at your wrist, your femoral is inside of your groin, your popliteal is under your knee, and your pedis and your pedal pulse is like in your ankle, right? It's always good to know, obviously, to check your leg pulses because as I mentioned earlier, like say if someone doesn't have a pulse in their ankle, that's a sign that they're not getting enough blood circulation to their leg, right? Another thing is if you're assessing, say you're assessing the pedal pulse on both the legs or both the arms, or say you're assessing the radial pulse in both the arms, you want to make sure the pulses are equal. Because keep in mind, when most people assess a patient, they only assess, say, the radial pulse of, say, one arm, if they do even check the radial pulse, right? But if, say, you might have a patient that say they have a really strong radial pulse in, say, one arm, but their radial pulse might be absent in another arm. And that might be a sign that they have a aneurysm, which is basically like a torn aorta. So if I Google aortic aneurysm, enlargement of the aorta. So what's the other aneurysm I'm thinking about? There's another one that I'm thinking about. It's aorta tear. Aortic dissection. So an aortic dissection is basically when your aorta like rips, basically. And this could happen to like a number of reasons. A common cause of it is cocaine abuse, because if you're doing a lot of cocaine or like a lot of caffeine or a lot of energy drinks over time, your heart is basically just, they say heart explode or tear, and it can do that. So you see that there's a tear in the aorta. Basically, when you have a tear in your aorta, you're gonna feel chest pain, like pain towards your back and like your upper, like up in here in this area. You're gonna feel the pain, but also when you have a tear in your aorta, right? That could mess up your blood circulation, so you might have unequal pulses. So unless you assess both pulses, you might have completely missed that, right? So yeah, those are all your pulses, useful to know. And that covers basically everything of my paramedic assessment video. Um, yeah, as I mentioned, make sure you do a full patient assessment. Make sure you obviously do a general impression. Make sure you assess the patient's levels of consciousness. Get your baseline vital signs. Do your rapid trauma assessment. Make sure that there's no external life-threatening injuries. Um, and that's it. And then that's patient assessment. Um, then obviously, once you find out all the physical problems going on with the patient, then you could do more of like going to your patient history and asking your history questions, and then going into more of your medical assessment questions. But this is more of just like a kind of trauma assessment and assessing the patient anatomically. So, hope you enjoyed this video. I hope I've educated you. Reviewing this definitely helps me with my own school, my own notes, and I hope you learned something as well. Goodbye. Have a great day.